So this discussion is going to look at pain and pain relief. So we're going to look at the physiology of pain and discuss some of the, the anatomical structures involved with the sensation of pain, different types of pain experiences and what that means for your patients. So when we look at pain, and really this is going to be what most of the modalities, physical agents that we're going to look at over the course of the semester are going to be centered on relieving pain. So we're going to be looking at a lot of things. It's always one of the first goals in the rehabilitation plan that we kind of look at. So one of the things is to, start to reduce and eliminate pain so that individuals can get back to function. So what is pain? Well, pain is an unpleasant physical and emotional experience. So key part of this definition is right here. It's also an emotional experience. So beyond the physical aspect of pain that occurs because we damage, soft tissue in the body, we suffer some type of injury, pain is multidimensional, and that requires a lot of things in order to address it. So it's really important to kind of note as we kind of go through this some of the things that we may have to deal with when looking at someone's pain experience. So as far as a clinician goal, the idea is particularly with the physical agents that we utilize is to look to reduce pain so that we can do therapeutic exercise. So as I mentioned before, therapeutic exercise is really going to be the thing that is kind of basically the thing that's going to really fix the patient, okay? Again, a lot of the physical agents that we're going to talk about are great for facilitating that process, but they're not inherently going to make the patient better by themselves. They're going to facilitate activities that are going to enable them to do that. So pretty much every time you have someone with some sort of injury, we're looking to reduce their pain. An important thing to note, it's a good way to be able to, it's good to always be able to figure out why they're having the pain. So beyond the injury, so pain's not always related to tissue damage. In other words, pain can sometimes linger beyond when it's useful. So we know why we have the experience of pain. It's to tell us that there's something wrong with the body. So if if you sprain your ankle hurts because that's your body's way of telling you that you injured your ankle. There's something wrong with your ankle. But we also know that pain can last beyond this, and that's why it's such a multidimensional experience. And a lot of times, particularly due to changes in the central nervous system, particularly through something called central biasing, sometimes there could be some prolonged pain even when the tissue damage isn't there. So that's why it's important to address pain as early on as you can and try to get the patient back to pain-free normal function. Okay, so pain transmission. So, in our body, our nervous system, we have peripheral sensory receptors that basically send information to our brain to let us to give us various types of information. And we have different types of sensory receptors. We have special receptors. So special receptors are responsible for things like sight, taste, smell, hearing, balance, that sort of thing. So they're sensory receptors. We also have visceral receptors. Okay, visceral receptors are in our organs, and they tend to perceive things like hunger, nausea, distension, and visceral pain. So if someone, for instance, damages an internal organ, they experience visceral pain. It's from those visceral they will get pain from those visceral receptors. Now, the special and visceral receptors don't really involve themselves when it comes to musculoskeletal injury. The ones that we're concerned about as it relates to musculoskeletal injury are superficial and deep sensory receptors, and these are going to be the receptors. These are your mechanoreceptors, your thermoreceptors, your nociceptors. These are the receptors that are going to be basically we're going to be looking at as far as what occurs when you have a musculoskeletal injury, and the things that we're going to have to address in the way of pain and through rehabilitation. So we're going to look at these different types. And again, so the peripheral receptors that we're concerned about, they break down into superficial versus deep. So our superficial receptors, they transmit sensations like warm, cold, touch, pressure, vibration, itch, pain from the skin, okay? Whereas the deep receptors transmit information about joint position, kinesthesia, deep pressure, pain from muscles, tendons, fascia, joint capsules, okay? A lot of those deeper tissues that we classically think of when we look at a lot of the things that occur with musculoskeletal injuries. So these will transmit information from the periphery and then allow the person to experience pain once some type of trauma occurs. And with modalities, we look to basically modify that pain signal. So with our modalities, we can affect pain transmission in 3 different areas. We could affect transmission from the periphery, in the case of peripheral nerves. We could also modify pain at the level of the spinal cord and actually at the brain. So, and in some cases, you will have some modalities that do more than one. For instance, cold works really well at the periphery. So when you put cold on an area, that tends to modulate pain at the periphery. When you utilize TENS, okay, or some form of superficial electrical stimulation, that could affect you at the periphery. You could also, depending upon how you change the parameters, you can also affect it at the spinal cord and also at the brain. And, once we get to the point where we discuss that, we'll talk about how you can modulate those different parameters. So here we have the different types of peripheral sensory receptors. So again, these are the ones we're really concerned about as far as musculoskeletal injury is concerned. You see this is in your textbook as well. You have your superficial receptors. So you have your mechanoreceptors, which are your Meissner corpuscles, Pacinian corpuscles, Merkel cells, and Ruffini endings. So important to note here, Merkel cells and Ruffini endings are a little more slow adapting, so they require a little bit more of a sustained stimulus in order to become active. So those mechanoreceptors are responsive to pressure and touch and skin stretch and pressure. When you look at you have your thermoreceptors, you have cold and hot receptors. Obviously, they're responsible at temperature and temperature change. And superficially, you have nociceptors, which are your free nerve endings. Now, in the case of nociceptors, again, they're very sensitive to the different aspects. If you think of all the things that cause pain, so you have mechanical stimuli that can cause pain, obviously stretching and tearing of tissue, the chemicals that get released during the inflammatory process, things like your prostaglandins, bradykinin, substance P, and thermal pain. So obviously we also know too that, for instance, if you touch, a hot pot on your stove, it burns your hand and it hurts. Now, interestingly enough, here you have an interplay between these receptors. So thermoreceptors obviously sense heat, but at the point where skin damage is going to occur, it's not the thermoreceptors that then are really providing the stimulus. It's now your pain receptors. So if we're looking at heat and skin burns, things of that nature, once it starts to denote that it's enough heat to start to damage the skin, that's when you'll start to experience pain. Then as we go into the deep receptors, okay, you have your proprioceptors, your Golgi tendon organs. You also have Pacinian corpuscles and Ruffini endings. Again, in this case, Ruffini endings are still very slow adapting in the deep proprioceptors. So you have, again, changes in muscle length and muscle spindle tension. So Golgi tendon organs, these are important ones to know because you'll hear about these also when you talk about therapeutic exercise. So Golgi tendon organs are pressure receptors that kind of monitor muscle tension. So they're kind of an important one to know. You'll be learning more about them in other forms, talking about therapeutic exercise. And again, we still in the deep area also have nociceptors. So the deep tissues that, again, when they're damaged, these will become very active when there's the need to transmit pain signals. So now we're going to look at the different ways pain gets transmitted. So the first kind of pain pathway we're going to discuss is this neocortical tract pain. So this is what we experience in an acute pain situation. So be thinking about your ankle sprains, muscle strains and tears, bone fractures, things of that nature. So it's this rapid 3-neuron sequence that we experience with this. So this happens very fast. So there's 3 parts of it, but it happens pretty much almost at an instant, with basically it ending with telling us where our pain is actually coming from. So at the first order neuron, the sensory nerve, that information, in this case our nociceptor, because that's the sensory nerve that transmits pain, is going to take that signal and take it to the spinal cord. Okay, so it's going to go to the dorsal horn in the spinal cord, or the back part of the spinal cord, and take that pain signal. There, you have the second order neuron, which is the T cell. So the T cell, and it's called the T cell because the T cell is responsible for transmitting that information to the thalamus in the brain. Okay, so the T cell, or the transmission cell, is going to take that information and it's going to take that up to the thalamus in the brain. The thalamus is your third order neuron, and then that's going to take the information to the sensory cortex at the brain, and then essentially what happens there is that's the area of the brain that will identify where the pain is. So if you sprain your ankle, you know right away that the pain is in your ankle because you have this 3-step sequence that basically takes that information to that area. And we describe this as what we call first pain, or call it localized discriminative pain. So it's where we kind of say, this is the injured part, we know this is what we hurt, okay, when we're doing it, okay? This picture here kind of illustrates simply how this happens. So if you look at the picture here, so, let's just say they stubbed their toe, okay? So again, here's your first order neuron, so the nociceptor to the spinal cord. At the spinal cord, the pain is going to come in through via the dorsal horn. It exits through the ventral horn, so the transmission cell is going to take it up to the thalamus, and then the thalamus takes it to the sensory cortex in the higher area of the brain. So first order, second order, third order. Okay, and again, this all happens very rapidly once injury occurs. So this is pretty much instantaneous. Okay, the second pain tract is what we call the paleocortical tract. Now, kind of the idea behind this tract, so this tract follows what we call Melzak's neuromatrix theory of pain. So multiple inputs affect the magnitude and overall pain experience. So again, pain goes beyond just, you tear some soft tissue, it hurts, your body knows it hurts, and you deal with it. There's multiple things that kind of impact your pain experience, and we see this with this is where that comes into play with this tract of pain. So this is where we get, again, the emotional centers get involved. We basically get other parts of the nervous system involved, shaped based upon our memory and things like that of past pain experiences. So then that kind of dictates what the current experience that an individual may be having who is experiencing pain. As far as the information, the way the information travels is the same as the neocortical tract. You have a nociceptor, okay? That's going to be taken. Now, the difference here is, and this is kind of a key part of this, is that it's taken via a C fiber, which is an unmyelinated sensory nerve, and it travels much slower. So part of what's going to happen here is the information is going to travel a little bit slower, which then that's where we get into other parts of the nervous system being involved, okay? So there's your first order neuron. This, again, in the case of this, it's going to be a C fiber, which is unmyelinated and slow. It's going to go to a T cell and then into the supraspinal areas of the brain. Okay, so the tract itself is similar. You're just going to get more things involved with the nervous system because of the slower speed. And these are some of the different areas that are going to become active. And important to note, these areas, the limbic system, periaqueductal gray area, the reticular formation, and the raphe nucleus, are kind of all areas where you can also help to modulate pain. So while they're involved in the pain experience in the case of the paleocortical tract, they're also things that we will modify through physical agents to help an individual in relieving their pain as well. So these other areas up in the higher regions of the brain, if we kind of look at this, so the limbic system is responsible for our emotional centers. So they kind of help to kind of modulate the kind of the emotional response to pain. The periaqueductal gray area, the reticular formation, and the raphe nucleus, those are centers for things like attentiveness, well-being, sleep, motor activity. They also get activated, and again, those brain centers also have a role in the descending pain modulation that occur as well. Okay, so that's an important thing to note. So those are different areas within the brain that are going to be active there. The periaqueductal gray area is actually going to direct something called descending inhibition, which we'll talk about what that is later on, so you'll kind of get to see that. The reticular formation is just a diffuse network of neurons that mediates motor, autonomic, and sensory functions. And again, the raphe nucleus is just another higher brain area that also, kind of works with the periaqueductal gray and the reticular formation. So it works with them it works with those other two areas in as far as, again, attentiveness, sleep, motor activity, and it participates in that. So again, we'll kind of talk about that. The raphe nucleus also is responsible for releasing serotonin and just, again, modifying our level of arousal and well-being. So that's kind of the little individual responsibilities of each one of those different areas. And again, this is what we call second pain, or the affective motivational response. So, in the case of kind of like a long-term pain or even an acute pain, again, pain that lasts beyond its usefulness. Okay, so again, we know we have pain to tell us where we're hurt. Even beyond knowing where we hurt, we still have pain. So this also kind of impacts that sort of pain as well, when you're kind of looking at how, after an injury occurs and kind of what that pain experience entails. So it's important to know this. So again, what's different about this as opposed to what we talked about, again, the tract kind of operates the same way. You have these three different levels, the difference being the speed of which it does, and the difference is because it travels a little slower, the T cell also involves these other areas of the brain. Again, the limbic system, periaqueductal gray, reticular formation, and the raphe nucleus. So these are the afferent pathways. So I talked about the C fibers, okay, those unmyelinated slow fibers that we experience with that type of pain, but these are looking at the other important first order afferent or sensory nerves that we're dealing with, both in the pain experience and kind of how pain gets modulated, okay? So looking at these, so the different types, so we have A beta and A delta. So your A beta fibers, okay, so these are very easy to stimulate. They're very low threshold. You see they're bigger than the A delta. They have a faster conduction velocity. They're responsible for touch and vibration, okay? Again, these are very easy to stimulate. So the example I always give, I'm not sure if it's in your textbook or not, I'm not sure where I got this from, but if you've ever lost your sunglasses on your head, okay, meaning you kind of bring your sunglasses up from your eyes and you rest them on the top of your head. A few minutes later, you're looking frantically for your sunglasses. Well, the reason being is that the sensory receptors of touch kind of adapt it so you don't feel it anymore. You don't feel the sunglasses actually sitting on your head because they've adapted. Now, interestingly enough, when we look at the A delta fibers, these are a little slower than A. These are actually responsible for your pain transmission, okay? More specifically, your A delta fibers are responsible for acute pain transmission, okay? So there's more information there to signal as pain rather than touch. So you'll notice that it says touch and pressure as well. They are more important as far as transmitting pain. So the acute pain that you feel comes from A delta fibers. Okay, then you notice on the bottom we have the C fibers. They're unmyelinated, very small. Again, they do transmit other types of sensory information. C fibers also have efferent fibers to the sympathetic nervous system, so that's important to note as well as far as what their function is. But your C fibers are going to be responsible for transmitting kind of that slow pain experience, okay? So what that basically means is when you think of like, prolonged, persistent type pain, that, dull, aching type pain, that's what your C fibers carry. That's as opposed to the A delta fibers, which are more responsible for that sharp, stinging, burning type pain that you would get, again, classically with a more acute type situation. That comes from your A delta fibers. Now, A beta fibers aren't involved in the actual injury pain experience, but what we'll actually do in some circumstances is actually utilize the A beta fibers to modulate pain, okay? And we'll talk about how we do that through different physical agents and their specific parameters. All right, so moving up as we go, so we just talked about the afferent pathways as it relates to the peripheral nerves, and as we said, that pain information is going to travel along those peripheral nerves to the spine and then to the higher areas of the brain. So we know that the supraspinal centers are the target for the second order afferent. So as we described, we have the first order from the pain fiber that takes it to the dorsal horn of the spinal cord. At the dorsal horn of the spinal cord is where the transmission cell is. That's your second order. The second order is then going to take that information to the thalamus, okay? And again, this is part of where the sensory discrimination and the affective motivational aspect is going to take place beyond the thalamus, okay? So the thalamus is where your third order neuron is, as we had previously described, and that center is going to then take it to the sensory cortex for the discrimination aspect to find out, locally where the pain is present. And it should be noted that both pleasant and noxious stimuli travel in that kind of ascending fashion. So, the brain and the nervous system is going to be interpreting both of those types of stimuli. If you kind of look at this picture that's in your textbook, it's just kind of breaking down, and it also talks about, which we're going to be mentioning coming up, a lot of the areas of the brain stem that are responsible for even the inhibitory aspect and some of the regions that we'll actually use through the application of applying some physical agents to modulate pain. And of course, the body itself looks to modulate pain through processes as well. So a lot of the structures that we talked about, you can see here, the raphe nucleus, the periaqueductal gray matter, and the reticular formation. So anatomically, you can see where all that falls. But again, remember the responsibility. So you'll have to know the responsibilities of all of these areas as it relates to both the interpretation of pain and also how we modulate pain or reduce pain for our patients through the use of physical agents. Okay, so now kind of moving beyond how pain travels in an ascending fashion, we're going to look at our descending pathways in our nervous system and kind of talk about how it functions. It could function in two fashions. It could function from the standpoint of being excitatory or inhibitory, depending upon what the impulse is coming from that are getting transmitted in the spinal cord. So as we had mentioned, so pain transmission is an afferent sensory signal. And basically what it's going to do, it's going to travel in an ascending fashion up to the sensory cortex where that signal gets processed. But because of some of the other regions, particularly those regions that we talked about when we were discussing the paleocortical tract, so those other areas in the brainstem, and because of the influence they have, again, it's not just as simple as someone gets hurt, the body part sends a signal, and then where it's injured. There's other things along the way that kind of get involved in that other tract as far as being able to interpret pain, particularly as it relates to, again, the affective, emotional response and kind of what your past pain experiences are. So there's other influences there. But these descending tracts that we're going to talk about, again, they could work in two different ways. They can look to inhibit pain. And again, there's going to be modalities that we utilize based on their parameters and the type of characteristics that they have that actually amplify that response to further inhibit pain. Or we could have a situation where the pain kind of lasts beyond its usefulness. Again, kind of depending upon some other factors with kind of how this gets handled. So again, so the activity that's going to occur through the descending pathways is either going to be either excitatory or inhibitory, and we'll kind of talk about how how that could happen in either fashion after the sensory cortex receives the input. Okay, so after your sensory cortex receives the input, there's going to be other factors that kind of play a role, particularly, again, we talk about the influence of the affective and emotional responses to pain and things of that matter. What we're looking to do from a musculoskeletal rehabilitation standpoint is we're looking to kind of manage pain in some instances, depending upon what type of pain the person's having and kind of where they're at in the rehabilitation process. We actually want to look to target descending pathways to actually help them manage pain. And the body also looks to do this as well. The body kind of has its own sort of pain modulation system that it can also use. We just kind of look to amplify that and sort of leverage it to be able to decrease somebody's pain. So, and again, this is going to include all those areas that we talked about in the paleocortical tract, and we're going to see how these different areas, the periaqueductal gray reticular formation and the raphe nucleus, and kind of how they all have the potential to affect the perception of pain through descending mechanisms. Okay, so it's going to be important that these areas of the brain, and again, the brainstem, and again, we're going to look to use this. Another area that's also important in the central nervous system up and around the brain is the pituitary gland. So the pituitary gland, which we're also going to be talking about as it relates to pain control, is also going to secrete hormones that are also going to further look to modulate pain. So again, we're looking as clinicians to kind of leverage these descending pathways. However, again, this could work both ways. These same descending pathways can also lead to, depending upon if there's what we call hyperstimulation. So this idea of wind-up actually will occur in the case of, when you look at people that have persistent pain syndromes, or when pain kind of again, we talked about pain kind of outlasting its usefulness. Again, pain has a use to us because it tells us that something's wrong, but after a while, we obviously don't need that, and if it lasts beyond that, it actually becomes a major issue as far as getting past the injury and kind of prolongs that process. Well, if for some reason this noxious stimulation kind of gets out of control, it kind of results in a pain syndrome that lasts beyond its benefits, beyond just alerting the person that they're hurt. Okay, so for instance, if somebody doesn't get treatment right away, they sort of delay kind of controlling their pain. What essentially happens through mechanisms within the central nervous system, those C fibers get hyperstimulated. So the key being here is sustained C fiber input from that paleocortical tract, and then what ends up happening is the person kind of has, again, that prolonged pain that kind of inhibits them from getting beyond the pain associated with the injury. So this is what would classically happen in your persistent pain syndromes. Again, proper treatment can help prevent this. Okay, and this is what you're looking to try to prevent through a lot of the things that you're going to do early on as it relates to a lot of the interventions that were going to occur. And sometimes this could even incur, it doesn't even necessarily mean they were treated inappropriately, but sometimes just insidiously, it can also happen as well. You just have to be able to recognize this as soon as you can, because a lot of times it's the persistent pain issues that could be, you know, the most difficult to deal with. So essentially what ends up happening is you just basically get an altered transmission through, you know, this hyperstimulation of the C fiber input, which then just kind of prolongs the pain process. And there's things like neurotransmitters, particularly substance P, you know, along with some other you know, chemicals in the body that are getting released that further enhance that process of that prolonged pain.